November 2nd, 2020. We had a pretty nice weekend, and we're going to have a nice week. It's going to be near 70, or actually in the low 70s, at least here in mid-Missouri for most of the week. So I thought I would, so we talked about CoQ10 and statins and cardiovascular disease. So I thought I would transition into high blood pressure treatment since I had an episode yesterday that made me kind of rethink this all the way around. And I remember when I saw my blood pressure doctor in July, his nurse was an emergency room nurse for 27 years or something. And I mentioned that episode that I talked to you about earlier this summer, where I had taken all my high blood pressure meds, there's 5 of them, before I went in to teach at the high school. Um, and I took those medications at 7:30, and by 9:30 I was having chest pain and felt like I was lethargic and tired, felt dizzy, felt like I was going to pass out, and I took my pulse, and it was 41, which is emergency room level pulse. So I got up and ran around the halls in the room, just walked to get my heart rate up, went down to the school nurse. My blood pressure was 122 over 70, which, you know, better than 227 over 118 like I had been running before I remedicated. And I've been fighting this since I was about 30. I had a friend of mine from residency who I had seen one day who came back in after my blood pressure was 160 over 110 and had me take a sublingual nifedipine and said, if it doesn't come down, I'm putting you in the hospital. Well, if me being in the hospital with a blood pressure of 160 over 110, if that was hospitalization level, I would have been in the hospital hundreds of times since I was 30. Good morning, Eileen. Good morning, Wendy. So I thought I would revisit this because yesterday morning I took my full dose of labetalol and my hydrochlorothiazide and my spironolactone. I had taken my irbesartan and half of a labetalol the night before. So I play with my medication doses and I just let my doctor know what I'm doing. So I always think about people that just take medication like it says on the bottle. Um, because if I took my medications like it says on the bottle, like I did the day I was teaching, um, I'm not going to say I would have died, but I was having trouble. So there is a point that if you get your blood pressure too low, and if you're taking a beta blocker, your heart rate too low, you're going to not perfuse your heart muscle, which is what was happening to me that morning. Hey, Linda. So when I was talking to the nurse that took my blood pressure, and I had taken, trying to think that morning if I had taken my blood pressure meds. I think I had. Maybe not. I can't. I think I wanted to let them see what it looked like without meds. I think I was 180 over 102. And she asked me, she said, how do you feel? And I said, I feel fine. If I get really high, I can tell. And I know that from wearing a 24-hour blood pressure monitor called a Holter monitor when I was in residency. And most of the time, my blood pressure was like 130 over 85, 130 over 82. Um, and the thing that triggered me was traffic. And I was living in Omaha, so if I was in heavy traffic, my blood pressure would shoot up. So I teach human physiology, and the other part of me talking about this is we talked about hypertension in physiology class last Thursday. So what happened to me yesterday was I did not take my blood pressure. It's kind of hard to take your own blood pressure. I use a cuff, so I have to kind of do it around and put a stethoscope on my brachial artery and take my blood pressure. And the cuff gets twisted, blah, blah, blah. So I probably need a better cuff. My doctor thinks the electronic ones are okay. My nurse friends always say if you want to take a blood pressure, use a cuff. So I had taken my medication yesterday morning, and that was about 9 o'clock. By 11, I could barely stand up. I was walking through the dining room, almost passed out. I got that pre-syncope, kind of dizzy, tingly eye things. So I had to sit down and basically sat for the rest of probably 6 hours, so that I could tone down the effects of the labetalol that I had taken. So my pulse was about 52, and what I realized is I probably need to take my blood pressure before I take meds. I found out about 2 weeks ago, if I go to a store and they got a blood pressure kiosk, I'll sit and take my blood pressure. With no meds, my blood pressure 2 weeks ago was 143 over 86. So if I would have taken all my meds, I would have gotten all kinds of symptoms. So it got me thinking, okay, how many people really overtreat hypertension, and how did that develop, these guidelines for hypertension? So it came out of the Framingham Heart Study, which has been going on for 50 some years. And before the Framingham Heart Study, where they looked at cholesterol and this and that and the other thing, nobody took blood pressure. So blood pressure became part of your vital signs, and then that's developed into these guidelines for blood pressure. Well, in physiology class, and we don't do labs anymore because of COVID, one of the labs in physiology is to take blood pressures before and after you dunk your hand into ice water. So blood pressure is fluid, and that's what I taught the physiology class. Most people are considered to have essential hypertension. We'll talk about that here in a little bit. But if you take a blood pressure before and after you dunk your hand in ice water, your blood pressure will go up. So you really have to realize there's nothing really that raises blood pressure unless there's an underlying reason. So the average adult blood pressure is 120 over 80, and that's kind of used to be what everybody shot for. So now they're saying, pre-hypertension is 115 over 80, 115 over 85, which when I was in medical school was a pretty good blood pressure. Okay, so the other thing is how they measure it. So I'm sitting in a kiosk, sitting straight up, which is probably not the best way to measure your blood pressure. Your blood pressure probably should be measured while you're lying down and not talking. So the little kiosk that I go to says, make sure that you're not talking to anybody while you're having your blood pressure taken. So even talking will raise your blood pressure. Okay, so the measurement techniques are typically at the doctor. You're perched on a exam table, or maybe sitting up. You hold your arm out. They have you uncross your legs, which people sit when they cross their legs just routinely, so that raises blood pressure. They put a blood pressure cuff on you, and they usually start asking you questions. They'll talk about the weather, like I do all the time, or they'll talk about where you're from or what you do for a living, and blah blah blah. And so your blood pressure will raise just based on that. So hypertension, based on the Framingham study, is considered 140 over 90. So now they have pre-hypertension and borderline hypertension, and then there's severe hypertension, which is probably me. About 5% of the time you can find a reason, a medical reason. So for mine, it's a little bit of renal artery stenosis, and that's probably been going on for a number of years. I mean, most people in their 20s and 30s don't get stenosis of their renal arteries, but I had an ultrasound a year ago, and I have maybe 50% stenosis of my renal arteries, so the blood flow to my kidneys alters my blood pressure reading, not on a blood pressure test, but my kidneys are thinking that I have low blood volume. I mean, you send 180 liters of blood through your kidneys a day. Well, if you reduce that amount by, stenosis of an artery, then your kidneys think that your blood volume is low, and so they'll put out hormones, the renin, angiotensin, aldosterone system, to tell your heart to increase its rate and to increase stroke volume, et cetera, to try to get that blood volume back up. Thus, you get hypertension. So that's about 5%. So we teach in physiology in medical school the most common form of hypertension is called essential hypertension. Okay? Well, essential doesn't mean anything. It means blood pressure elevation for no apparent reason. Okay? So you can also, in class, if you do a lab, you can do something simple like take a baseline blood pressure. Theoretically, you would have them lay down in the lab. And of course, COVID-19, we can't even have a lab. You have them lay down and then start a mental exercise like counting backwards by sevens from 100. So 100, 93, 86. And then measure blood pressure while they're doing that. And sure enough, your blood pressure will go up. Okay, so typically the goal is to get you really under 120 over 80, which is the average blood pressure for an adult. Okay, so sure enough, and I'm going to look at this study while I'm talking to you. And this goes back to 2009. Okay, so, and this is from Medscape, if you all have, I mean, it's not, the article isn't from Medscape, but the review is from Medscape. The study was done in Costa Rica. The headline is no benefit in lowering blood pressure below standard 140 over 90. So they're saying the standard is 140 over 90. So this was a review that was published in 2009, reviewed by Cochrane, which is kind of the the fake news of medical stuff. And so they explained, so from 2004 to 2009, that for those 5 years, a trend toward lower targets has been recommended by hypertension experts who set treatment guidelines based on the assumption that the use of drugs to bring the blood pressure lower than 140 over 90 will reduce heart attack and stroke. However, that has never been proven, and this is a review study, so it wasn't a double-blinded, placebo-controlled, blah blah study. But they reviewed trials with more than 22,000 people comparing lower or standard diastolic blood pressure targets. But they were unable to identify any studies comparing different systolic blood pressure targets. So the systolic blood pressure is measured while your ventricle is contracting. The diastolic is while your ventricle is at rest. Okay? So the statement from the lead study investigator was that there's no question that the 140 over 90 blood pressure limit is totally arbitrary, and the benefits of antihypertensive medications are most obvious in patients with the highest blood pressure. So theoretically, that would be somebody like me that would run around running 220 over 110 to 120 kind of routinely. But I do have renal artery stenosis. So the closer you get to normotensive levels, so 120 over 80 or lower, the more difficult it becomes to show benefits of blood pressure lowering. Okay, so so typically, if you look at the literature, most of the literature says that people fare better. In other words, they have fewer strokes and heart attacks when their usual blood pressure is 115 over 70, compared with those of a usual blood pressure of 130 over 80. But there's no data, and probably never will be, that lowering blood pressure from 130 over 80 to 115 over 70 shows any benefit at all. Okay, and then there is a review of what's called the INVEST study, and I won't bore you with what that means. They showed that lower is not better, it's actually worse. So the INVEST study was the first to evaluate the effects of blood pressure lowering using diabetic patients, so diabetics, who also had coronary heart disease or coronary artery disease. So these people are high risk for heart attack, death, stroke. So you don't really get riskier patients than diabetics with coronary artery disease. So what's true for these patients probably holds true over a vast array of normal, whatever you want to call them, normal patients are. So this was an analysis of data collected from 6,400 patients from 1997 to 2003. They were 50 or older, recruited from 850 sites in 14 countries. Okay. So the lead investigator said the range considered normal for healthy Americans actually proved riskier in cardiovascular events for those with a combined diagnosis of diabetes and coronary artery disease. So it showed a J-curve response. So if you get below that 130/80, you actually had a higher risk of cardiovascular mortality and death. So patients with diabetes, in this study, patients with diabetes and coronary disease, there's a blood pressure threshold below which cardiovascular events and risk increases. Okay? So it appears from her data that the ideal systolic blood pressure in a diabetic with coronary artery disease is about 130 to 140. I've also read recommendations based on physiology, basically, that says as you get older, so I'm 60, my normal blood pressure would be 100 plus my age. So if you think about if you're 40, then your blood pressure would be 140. If you're 50, systolic. The issue is what should the diastolic blood pressure be? So for me, 160 over 110 is probably too high. But we don't really know. I mean, it depends on who you read. There's all kinds of studies about, this and that and the other thing. So you may notice that blood pressure levels and cholesterol levels are kind of correlated together, parallels, even though nobody's really shown that. So when both of them are raised above normal, they're considered to be a cause of cardiovascular disease, and we've talked ad nauseum about cholesterol levels and cardiovascular disease having really pretty much nothing to do with each other. Your best blood test for risk of heart disease is homocysteine. Okay. So the experts now are saying that you cannot have a blood pressure level or cholesterol level that is too low. Well, that's not true. I took my blood pressure medicine yesterday and almost passed out. I'm sure my blood pressure was considered normal, but like the emergency room nurse in my blood pressure doctor's office, there is a level that is normal for that particular person. So just lumping everybody together and saying your blood pressure should be 120/80 may not be true. And she knows that from working in an emergency room and working for a hypertension, like a high-risk hypertension doctor. And she said, your normal blood pressure is probably 160/100. I'm 60. I've had no cardiovascular events. I'm not saying I won't. But it appears that lowering blood pressure has nothing to do with mortality. So in other words, getting your blood pressure under control will not help you live longer. That's what the data seems to show. And what happens is that we spend billions of dollars every year in an attempt to lower cholesterol and lower blood pressure. Okay? And of course, the level that's considered to be high, so that leads to treatment, keeps lowering. When I was in medical school, 140/90 was hypertension. And no one knows what causes essential hypertension. So 95% of the people with elevated blood pressure, nobody can identify an underlying cause. So the average blood pressure of an adult, maybe 120/70. The term essential, again, means blood pressure elevation with no apparent underlying cause. That's essential hypertension, which is what I taught my physiology students, is 95% of the people with primary hypertension. You can have secondary hypertension from pheochromocytomas, renal artery disease, etc., etc. But the vast majority of people are just told you have high blood pressure, we don't know why. Okay, so a raised blood pressure by itself is not a disease. Okay, it's not even a symptom of disease unless it gets really high, and I can tell when mine is high. So I learned that from wearing a Holter monitor. So if my blood pressure is too high for me, I can feel that kind of in my head. So raised blood pressure, it's called the silent killer because it doesn't have any symptoms. So when you get down to it, a raised blood pressure is a measurement made that's using a machine. Okay, so unlike measuring your height, for instance, blood pressure never remains constant. If you exercise, it will go up. If you relax, it will go down. If you're laying supine, it will go down. So the blood pressure is really reactive. One thing it is not is proactive. So it cannot just rise all by itself for no reason. So if the blood pressure raises, there's a reason. So if you get an elevation in blood pressure, there's a cause for that. Okay, so again, you can have renal artery stenosis like I do. You can have an adrenal tumor called pheochromocytoma, which puts out lots of epinephrine. That can do it. Okay, so in around 5% of cases of hypertension, you can find a cause. Again, in 95% of people, you can't find a cause. Okay, so again, we didn't measure blood pressure in the doctor's office probably till the 1950s. I didn't research that specifically. But so essential hypertension kind of turned from a measurement into a disease rather than the body's natural reaction to some underlying problem, be that anxiety, be that a tumor, be that this, whatever. So a whole series of drugs have been developed that come at you from all different mechanisms. So some reduce blood volume, some relax the blood vessels, like hydralazine, some block production of hormones produced by the kidneys, others stops the heart from pumping so hard. They're known as thiazide diuretics, which have low potassium as a side effect, so you have to take potassium on top of that. Beta blockers, alpha blockers, angiotensin converting enzyme inhibitors, angiotensin 2 receptor inhibitors. So after statins, they are the most prescribed types of medications in the world, antihypertensives. Okay, so even though we've developed all these medications for that, in the early days of drug development after the Framingham Heart Study data started coming out, there were almost no controlled trials done to see if they actually did any good. So there are a couple of short-term studies on people with really high out-of-control blood pressure, like me, but when it came to people with mild or moderate raised blood pressure, which is the vast majority of people with essential hypertension, there were really no studies at all. There were no placebo-controlled studies for antihypertensive drug therapy. It was just accepted that if blood pressure was lowered, you were doing a good thing. However, they have side effects. So, and I've had them all. Angina, so chest pain, your heart, a beta blocker slow your heart rate. If you're not perfusing your heart muscle, you get angina. Maybe I have coronary artery disease or not. I'm not sure. I've only had angina twice. The times I've had angina are when I had taken my labetalol at full dose. So it was not really until the 1970s before they started out looking at the answer to that question. All these medications, side effects, erectile dysfunction, dizziness, tired, fatigue, lower heart rate, angina, this, that, and the other thing, off balance. So does lowering blood pressure in people with just moderately raised blood pressure do any good? So there was a study in 1973 where they recruited people. They had 500,000 people accepted as an invitation to participate after they contacted 700,000 people, and they whittled that down to just under 18,000 people with diastolic blood pressure of 90 to 109 and systolic blood pressure that was higher than 140 but under 200. That was reported in 1985. The results, well, if you get down to the most important result of all, which is overall mortality, death, there were 248 deaths in the group that was treated with antihypertensives, and there were 253 deaths in the placebo group, no treatment. So moderate hypertension, same amount of deaths, actually 5 more in the placebo group that weren't treated, 248 in the treated. So 9,000 people out of 18,000 were treated for raised blood pressure for 5 years, and at the end of the study, 5 more people were alive in the treatment arm than the placebo arm. So a completely unimpressive result, and probably was just based on a chance finding. So the study failed to completely reach the holy grail of statistical significance. Okay? So it seemed from this large study that lowering mild to moderate blood pressure elevation was of no benefit. Certainly not when you set it against billions of dollars and all the years of potential side effects. Okay? So you would think that would get everybody rethinking the whole area. It didn't. Crickets, no, it was swept aside, a veil was put over it. Okay? So in fact, once the dust settled, the goalposts were pulled out of the ground and moved based on no data. So there was no impact on heart disease, there was no increased life expectancy, there was a small but statistically significant effect on stroke. So as the statistics was 1 stroke delayed for around 900 years of treatment. That's the statistics. And of course, we talked about Mark Twain and statistics. So other studies have shown the same thing. If you think stroke is due to an artery in the brain bursting, which is the least common stroke, then the idea of lowering blood pressure may reduce the risk of arterial bursting. So arterial bursting, cerebral hemorrhage in your circle of Willis. So stroke is a disease that fits into the group of cardiovascular disease, which it sounds like has something to do with the heart, but it really doesn't. So instead of looking at overall mortality or heart disease, high blood pressure drugs are measured on their impact on cardiovascular disease. And when those studies are reported, they are normally also reported as a composite endpoint outcome. Well, just like statin reduction of cholesterol, doing nothing for mortality doesn't change your rate of death from cardiovascular disease. Shouldn't that be the endpoint? What's your risk of death? Okay. So there's a veil that's been drawn over the fact that reducing blood pressure has no effect on heart disease or life expectancy. It really doesn't. Stroke, maybe, so you avoid 1 stroke with 900 years of medication on lots of people. Okay. So basically, and I won't go through the boring statistics about how they came up with development of guidelines, but the guidelines basically based on the statistics called log linear statistic model. So it's a mathematical way of smoothing out data. Okay, prove that type of looking at numbers prove that the further you can drive down blood pressure, the better. And you can do all of this without the need for any data. Okay, so one problem is that log linear data, and like I said, I won't go through all the boring numbers. As a matter of fact, the one course that I dropped in college was statistics. It didn't make any sense to me. So 20 years ago, Ancel Keys, I brought him up with the diet heart hypothesis, which he refuted before he died in the 1990s. He said all the stuff that I put out there about cholesterol and heart disease is incorrect, and we knew it. So Ancel Keys concluded that that model that he used was wrong. Okay. So a group of medical statisticians reanalyzed the Framingham data, which underpinned the log linear statistical model, and those statisticians concluded that we have found that the Framingham data in no way supported the current paradigm to which they gave birth. In fact, the paradigm must be false. And then they went on into a heart journal and said no randomized trial has ever demonstrated any reduction of risk, either overall or cardiovascular death, by reducing systolic blood pressure to below 140. Okay, so that statement was made. That fell on deaf ears. Nobody paid attention to it. So this is statistic. Everybody talks about medical statistics and blah blah. You have to do double-blind, randomized, statistically evaluated studies. So basically, the whole point is, I take a boatload of antihypertensives. I'm in that 5% that has some renal artery stenosis, which probably has something to do with my blood pressure management. And I've taken meds off and on since I was 30, so 30 years. I take them, it does nothing to my blood pressure. Now I'm on 5 of them, it can get my blood pressure low enough and my heart rate low enough that I have major symptoms, so I have to play with those. I have to play with the doses. I should be taking my blood pressure before I take my blood pressure medication. I don't feel hypertensive this morning, and I've taken nothing. Yesterday I didn't take my blood pressure. I didn't feel hypertensive. I took my meds and ruined 6-7 hours of a day, being dizzy and feeling like I was going to pass out. And then statistically, so that got me thinking, okay, what's the statistics show? Well, the statistics show no benefit of getting your blood pressure under 140/90. Now, I'm not saying that 227/118, which I've measured on myself, is good. That's probably a risk for hemorrhagic stroke in my head. But over, the essential hypertension, which means I have high blood pressure, nobody can figure out why, you can probably overtreat it. And if you get your blood pressure too low, you start raising your risk of cardiovascular disease. So that's my thoughts from Monday. I did it in 30 minutes-ish, 31. So think about all that. Look it up. I can put up a link to the 2000, I think it's 2009. That review article. I can put a couple links up when I get off here, so you can read it for yourself. So I will talk to you Wednesday, maybe. While I was doing this class, the principal of high school asked me if I could substitute teach, so we may have to do class in the late afternoon, Wednesday and Friday. Okay, so I'll let you know. Talk to you later. Have a great day. Hope your weather is going to be as good as it is in mid-Missouri this week. So I'll see you later. Bye-bye. Bye.